much. So I'm going to talk a little bit about consumers as health and research partners, nothing about us without us. And I'm looking at the logo, and here I think, I'm not entirely sure, but I think this is the university and the hospital and the foundation. And there's one platform that's not there, and that's the community, and that's what I want to talk about today. The first thing I want to say is that my intent is not to offend you. So I know that there are many clinicians in the audience of all persuasion, and I don't want to make any assertion that you aren't patient-focused, but what I would suggest is that we all have to do a little bit better. This is my hypothesis. In clinical care and research, the doers, that is the healthcare providers, the researchers, have largely dominated the agenda and not the users, the consumers, the patients. Even though we have a public good agenda, that's why we're here. They pay, it's their money, whether that be research or education or clinical care, and it's their outcomes that we're seeking to improve. So we can and we should be at the vanguard of this change. So let's talk a little bit about clinical care and a few exemplars: qualitative study, practice variation, models of care, and patient co-payments. So this is my sphere of interest is kidney disease, both adults and pediatrics. And here's one quote that came out of the many qualitative studies that we've done. Some doctors treat us like we're just sitting in their bed waiting to be told, okay, you can have this now, you can have that now. They think, well, you're just a patient, what would you know? So it's not to say that all doctors, all nurses are like this, far from it. Many actually have patients at their interest, but more could be done. Let's go from the sublime to the ridiculous. What about Botox for migraine? Well, this is the number of Botox services for migraine across the country from 2014 to 2016. This is funded through the Medicare benefits schedule. You can see that there's been a very steady rise. Well, then if we disaggregate this, so this is year and this is state and territory, and what you can see here, and I'm not geographically or demographically an expert, but I'd suggest to you that there are probably more than no people in Tasmania and Northern Territory, and that ACT has 1,300 services in 2014, and there are probably more people in South Australia than the ACT. So why is this, right? Does this represent demography? Well, no. Does it represent the fact that migraine only occurs primarily in the ACT? Well, the events over the last couple of weeks might suggest why that might be, but actually probably is not so. Does this reflect patient need, or does it reflect more about the provider? Well, let's look at who actually delivers these injections, and they're quite complex, but as you can see that 10% of healthcare providers across the entire country administer 50% of the services for Botox, and indeed 20% deliver 70%. In other words, we have a large number of injections being delivered by a relatively few number of people. What about how much do they pay? How much do they charge? This is the median fee charged, and you can see here in South Australia, the median fee charged by, this is over and above Medicare, which is down here, is about $150, so relatively modest. So you would say, and having been in South Australia for months, that this probably represents something which is culturally appropriate for this jurisdiction, whereas in the ACT, $350. So does that mean that the quality of the Botox injections in ACT is 3 times better than what is delivered here? Well, that would be absurd. This simply represents local provider factors. However, we look at the 95th percentile, we can see South Australia 660, ACT 350. So there's one or two in the community in South Australia who are charging a very great deal. So does this reflect So what does this tell us? Does this tell us about consumer-orientated care, or does this tell us more about the provider? You will have seen the Atlas of Healthcare Variation, which is this fabulous resource which demonstrates how often, as standardized by the number of people, a whole range of procedures are done. And this is hospitalization for lumbar spinal decompression. And what you can see is, on the x-axis, the scale varies between 40 and 160. So what are the centres who do this procedure the most? Well, it doesn't surprise you that this is far north Queensland and the Kimberley of WA. Does this represent that the need for this procedure is less in those areas? Well, where is it most common, 160, the eastern suburbs of New South Wales. What does that indicate? Does that indicate real need, or does it indicate that there are some factors which is actually a mismatch between the clinical care that's provided and which is actually administered? I would suggest the latter. So, this is a pinball machine. I would suggest to you that very often this is the setting in which patients feel that they engage with a healthcare facility, be that in primary practice or tertiary or quaternary. This is a patient pinball. How many of you have tried to navigate the healthcare system as consumers, or helped your friends, your family navigate the healthcare system? It's very complicated. It's not a consumer-friendly process that we provide. This is manifest in a whole range of ways. Sometimes they get treated as commodities. This is regarded in the lexicon, my patient. They ping between clinicians, such as this pinball machine. You know, I think if anybody wants to make some money, I would suggest a healthcare GPS, right? It enables you to navigate the really complex process even within the same hospital. We have an organ-based care versus a patient-level care. So patients have to go to a nephrologist, a cardiologist, and so on. There's no one-step shop. We require a high level of health literacy. They don't own their own records, and there's no resource for their own care. In other words, slightly different, if you look at the items on the PBS or MBS, they're all about delivery of specific services for the healthcare provider and not about patient outcomes. What about research? Well, so for me, the penny dropped in 2008 when I supervised this person, Alison Tong, who did a very simple thing, and I'm sure that you've had similar experiences. She just really asked people with kidney disease and asked them what their priorities for health research really was. Until then, I'd made the assumption that being a clinician and being a researcher, I knew what they really wanted. And here, actually, we just asked them. And in fact, some of the results were quite striking and different and controversial, and also the reasons why they came up with these questions was also illuminating. These were the things that they thought were important. Prevention, complications, you could argue actually no surprises, but this was 10 years ago. But they did say some other things. I think there's work to be done on the quality life side of things, more information and being formed about lifestyle and so forth. At that stage, there was virtually no trials about lifestyle factors, dietitian, dietary interventions, accommodation, transportation to and from care, whole body. Yeah, I think, do you guys talk to each other? You know, do you do collaborative research? I had the same problem. They've got different units for different things. It's not like they don't talk to each other. The kidney specialist looks at this part, someone else looks at that part, and someone else looks at that part. That's a contrary to how they see themselves, how patients, how we all see ourselves, actually is not disembodied pieces of one organ or another. So one group who's taken a lead on this is the James Lind Alliance, where they have done a whole set of what's called priority setting exercises, where they have sat down with clinicians, with patients, with families, and mapped what really is most important to them in terms from a research perspective. And this is the distribution of the types of interventions across a whole range of panoply of health problems that they regarded was most important. What we can see here is that they cluster around education and training, service delivery, psychological interventions, physical exercise, complementary diet, and other, where actually patients have some control out of what they can do. If they then compare the same sort of setting, but what is registered in terms of trial registers, what we can find is quite a difference, which is more around radiotherapy, surgical, perioperative. And if we look at registered commercial trials, we have a complete about face, which is mostly it's around drugs, vaccines, and biologicals. So it's not as if the consumers, patients, caregivers don't care about these things, drugs, vaccines, and biologicals. They do, except that they can compare about other things as much and if not more. That's about the research questions that are most important to patients. What about the outcomes? Because often outcomes in the setting of a clinical trial determine how informative they are. If the outcomes don't measure the things that really matter to clinicians and patients, then largely they're uninformative. And another group, the the OMRAT group, which is around rheumatoid arthritis and more recently extended into all sorts of musculoskeletal problems, have looked at the outcomes which are favoured by healthcare professionals and that which is favoured by patients in the context of clinical trials. And what we can see is that there are some where there's commonality, in other words, both groups think these are important, pain and function. There's quite a number of outcomes that are favoured by healthcare professionals, laboratories, these sorts of global quality of life measures, interestingly not so important as seen by healthcare professionals, and that which is favoured by patients are things like sleep, emotional distress, how to manage their condition, and so on. So have you seen this paper? Yeah. So in 2014, this paper and a series of papers were published, and the headline figure is thus. Every year, around 240 billion research is done around the world. That's a lot of money. That's a lot of people doing lots of stuff. But they estimate that of that, about 80% is wasted. Why is that wasted? There's kind of 5 broad areas. And I know Alison's going to talk a little bit about the translation and a bit later, and I look forward to that. But it's contingent upon the research that is done is actually important research that addresses real issues to real people right now. And this is the first issue which I've discussed in some time. It's not all doom and gloom. All right, my cough is going to get better. It's going to take another week or two, but things are improving and things are changing. And I think my challenge to you, as my challenge is to us, that here on this campus, I think we have an opportunity to be at the vanguard of change. Lots of organisations such as NHMRC are providing nice documents about how to do it, but actually examples about sustainable engagement with consumers, with partners, with communities to make this done. There is a real opportunity for us. So, in the BMJ, if you want to publish a paper in the BMJ, you now need to provide a statement in the methods section about patient involvement, which says actually you've engaged with patients, with community groups, and that which you are suggesting here as a priority for them, you need to demonstrate that's important to them. Cancer Australia, through NHMRC, you need to include consumers in your research. We've done, and other people have done, research priorities across kidney disease. This was done in 2015, whereby you can actually engage on a national level with consumers, and lo and behold, they came up with really sensible ideas and suggestions, and that can be turned into priority topics for trials, systematic reviews, and so on. I talked a little bit about the outcomes. This is a whole series of projects that we've done, which is developing standard outcomes in nephrology. When we do that, we find quite different interesting results. So these are a round of outcomes that are relevant for people with, on hemodialysis, which, as you know, involves attachment to a machine 3 times a week for about 5 hours, pretty grueling exercise. You leave, it keeps you alive, but it's dreadful therapy. What you can see here is that if we look at the outcomes that patients regard as most important compared to health professionals care about things like death, mortality, and hospitalisation, but actually consumers, patients, and their families less so. What they really care about is being off this dreadful machine. Not only in terms of clinical care, research, but also in terms of policy. So the PBS, as you know, pretty important process by which drugs, the effectiveness, the cost effectiveness of drugs are determined and determine whether they should be good for public subsidy. And you can see that the play of consumer comments is increasingly important. It's publicly funded money that allows us to subsidise these drugs. The PBAC is looking for consumers to provide real advice to them about the potential place of these drugs. So in conclusion, what we all want, what drives us, is about improved outcomes, whether that be in a clinical setting for patients or in a consumer or public health setting. Historically, it's been much too much about healthcare provider and researcher. More recently, structural changes are happening in research, prioritise problems and outcomes in policy making, and I've given you a few examples, and about clinical education. What can be done? Well, we need academic leadership here. We need people to say this is something that must have, and here's how I'm going to implement this in my sphere of influence and across the institution. We need community as partners. Aboriginal people, what's very important about Aboriginal research is the notion that if you're going to do it, you have to partner with Aboriginal communities. In this case, and as in others, Aboriginal communities are well ahead of the game. We need to learn from them and how research is done in Indigenous settings. We need culture change. Alison's going to talk about evidence-based practice. And we do have some fabulous examples here. Models such as comprehensive cancer centres, where you've got integration of research and education and clinical care in a shared facility. So those of you who are involved in the college would have seen our recent retreat. And this is the tagline: people, culture, excellence, and social vision. And social vision will be at the heart, and indeed is at the heart of our strategy. The college will place our social mission at the heart of what we do. The social vision provides a guide to ways in which an organisation can be more responsive to the communities it serves and works with and contribute to making society more socially just and less inequitable. And we have a pretty ambitious plan of how that would be rolled out. The other thing I've learned about Flinders is this extraordinary Central Australian corridor, I've been calling it, where you've got facilities, professional staff, academics, communities working everywhere from Mount Gambier all up to Darwin. And a few weeks ago, I had the opportunity of attending Katherine and wandering around the Katherine facility that there is. And this is what I came across. This is their library. Please ignore the Wi-Fi currently available in the corner here. This is the mantra that I saw. High quality care, consumer-centred, driven by information, organised for safety, partnering with consumers, patient-centred care, nothing without me, nothing about me without me. Thank you very much.